Ladies and gentlemen, now we are entering the fourth plenary session, practical aspects of IMRT and IGRT. I would like to request Dr. Mahilal Vijayakon, Consultant Clinical Oncologist, and Dr. Sachini Rasnayaka, Consultant Clinical Oncologist, to chair the fourth plenary session.
Thank you, Buddhini. Good morning, everyone. Welcome to the plenary 4, practical aspects of IMRT and IGRT. Let me introduce our guest speaker, Dr. Naduni Imbulgoda, Consultant Clinical Oncologist, District General Hospital, Vavuniya. Dr. Naduni Imbulgoda received her MBBS from the University of Peradeniya and graduated the MD in Oncology in 2014. During her advanced training abroad, she worked as a specialist registrar at Cambridge University Hospital for 2 years. Her research interests include image-guided radiotherapy to the breast and neuro-oncology. She also has a special interest in medical education. Over to you, Naduni.
Intensity modulated radiotherapy, IMRT, is radiotherapy in which the intensity of the photon beam is adapted to match the precise contours of the tumor. So we can get these very nice concave dose distributions in IMRT compared to 3D CRT in this prostate IMRT plan. Advantages of IMRT include dose escalation and sparing of normal structures, and the ability to treat multiple dose levels at the same time, which is a simultaneous integrated boost. So this is a practical IMRT prescription sheet, where this is a typical 65, 60, 54, 3-dose level head and neck IMRT plan. So we need to ensure that each of the 3 PTVs, PTV 65, 60 and 54, are covered with between the 95 and 107 isodoses. So therefore we put these dose prescription points here to make sure that the coverage is adequate. And we also have to decide the priority of each PTV and organ at risk in an IMRT plan. So this is the priority. This is the priorities. We have to set the proper priorities that we need. And also the organs at risk, we need to mention the optimum dose for each organ at risk and the threshold dose for each organ at risk. And in IMRT, we can also create special organs, special structures such as PTV organ at risk. So for example, in this GBM plan, of 60 gray is delivered to the PTV, but the PTV 60 gray crosses the brainstem here. So we can outline this special structure, PTV minus brainstem, and prescribe 54 gray maximum dose to this structure. So in that way, we can limit the dose to the brainstem. So IMRT is wonderful, but despite its wonderful abilities, it does have its limitations. So it has very steep dose gradients, and therefore there is minimum tolerance for random and systematic errors compared to conventional 3D conventional treatment. And also, so if the tumor shifts by a few millimeters, the target is missed. As you can see in this tomotherapy prostate plan, the 50% isodose is just a few millimeters away from the PTV. And if the tumor shifts, we will miss the GTV. So IGRT, 2010 ASTRO definition is image-guided radiotherapy is a procedure that defines the delivery of therapeutic radiation by applying image-based target relocalization to allow proper patient repositioning for the purpose of ensuring accurate treatment and minimizing the volumes of normal tissue exposed to ionizing radiation. So image-guided radiotherapy is the unsung hero of IMRT, as mentioned in recent editorial. So image-guided radiotherapy makes sure that the target is not missed and the organs at risk does not exceed tolerance. It allows changes in tumor position, size and shape that take place during radiotherapy to be measured and accounted for. So IGRT is nothing new to radiotherapy. So with the invent of radiation in the 1960s came the 2D plain X-rays in treatment position, which is the simulator images. And then in the 1980s came the electronic portal imaging devices, where we can see some amount of soft tissue and verify bony anatomy in 2 planes in the treatment position. Next came the 3D cone beam volumetric verification, which is the current standard for IMRT and was introduced 15 years ago, around 2005. And we also have real-time gating systems that detects displacement over a predetermined level, and radiation delivery stopped gated when it goes above the threshold. So real-time imaging with or without fiducials tracks respiratory motion during a fraction. It reduces intra-fraction error in lung and upper GI tumors. So this is dependent on availability of technology and is not freely available in Sri Lanka. So my talk, I will concentrate mainly on 3D CRT, 3D volumetric imaging, that is the cone beam CT. So what are the steps in verification of 3D volumetric imaging or the cone beam CT? So first we need to align the patient to the reference statues and take the cone beam CT image. So this is a typical cone beam CT image where we have the adjustments for lateral, longitudinal, vertical corrections, and this is a topo plan. So there is rotational adjustments as well, raw, pitch, and yaw. So what happens first is there is the automatic registration tool. So the radiographers first match the cone beam CT image to the planning CT image automatically. So the auto match is done by the machine, and radiographers will manually correct it to match to bony landmarks. The maximum limit that radiographers can adjust is 1 centimeter for the machine, but there are departmental protocols that the radiographers can actually match. So for head and neck, probably 3 millimeters, and pelvis 1 centimeter, depends on each department. And first, so after the bony match is complete, we need to assess the gross tumor volume in the cone beam CT. So this is a prostate plan. So we look at the blue, which is the cone beam CT image, and see whether the prostate we can see in the blue cone beam CT image is within the PTV of the planning CT. And next we assess whether the organs at risk fall within the high dose PTV. Verification. There is online verification and offline verification. So online verification is done before delivery of treatment. So the patient is on the couch awaiting treatment delivery. It compares reference images, planning scans with the image taken in the cone beam CT delivery room and corrected before treatment. Offline verification is the patient is at home, but we treat it, but after treatment, we check before the next fraction whether the treatment is ready to go, whether we are able to go. And then there is also real-time verification with gating, which involves intra-fraction errors. So online verification flowchart, can I treat today, is what we do in online verification. So there are 3 main concerns the radiographers address. One is the bony match correct? And then is the GTV within the PTV? And is the organs at risk not in the high dose PTV? Offline verification flowchart. Question is, can I continue treatment? Are there systematic errors? That is, errors in the same direction every day that would eventually make an outcome in the final treatment. So we consider that and check whether we need to make any adjustments, consider the targets, consider the organs at risk, and see what adjustments we need to make and intervene before the next treatment. So what are the challenges in IMRT to pelvis? So in the pelvis, there's a lot of organ motions where everything moves. The bladder, the small bowel, the rectum, the uterus, everything moves. So that's the main issue in IMRT. So there are a few strategies used for organ motion correction. The first and most common one is online repositioning based on 3D soft tissue imaging and daily cone beam CT. This is what we use at the National Cancer Institute in Sri Lanka, where we assess bladder, bowel filling and do corrections with daily cone beam CT. Now, some other things we can do is individualize patient margins and plan light piece and plan of the day. First one, which is online repositioning based on 3D soft tissue imaging, daily cone beam CT. So this is one of those cases. So I brought a few cases for you just to make it interesting. So this is a pelvic IMRT plan on day 1. So this is the planning scan, and this is the cone beam CT. So it's a bit blurry. So what do you see here, and what would you do? So this is the prostate in the planning scan. So here the prostate has shifted anteriorly, as you can see, because the rectum is distended with gas. So PTV has moved forward, and there's underdosing of the anterior bit of the PTV here, and this has been shown in numerous studies to cause a reduction in local control and biochemical response to radiation has all been reduced in numerous studies if proper IGRT does not take place. And also here, this bit of the rectum, as you can see, falls within the high dose PTV, and we can expect late effects for this patient. So rectal gas is a big issue in pelvic plans, so we need to ensure a proper bowel protocol is followed. And for this patient, the large rectal gas, we can ask the patient to walk around and empty gas, and sometimes simeticon, which is antiflatulence tablets, help, and then we can do a repeat cone beam CT. And rectal enemas are quite helpful. It reduces daily rectal expansion, and there are studies that has shown that rectal enemas daily is helpful in bladder as well as prostate IMRT plans. It's also helpful to avoid lactulose as it causes gas buildup in the rectum. And pain is also a main issue, so pain can cause rectal distension with stools, so therefore we need to give adequate analgesia for the patient during radiation. So this is my second case. So just have a look at this plan. This is the first plan on the 25th fraction, this patient, same patient. What has happened here? And what will you do? So obviously, like in previous, there's some gaseous distension of the rectum, but more than that, there is bladder underfill here as well. So PTV has moved forward due to underdosing of the bladder anteriorly due to bladder underfill. So this is quite common during the latter fractions of IMRT treatment, because the patient cannot, due to the radiation effects on the bladder, they get increased frequency and they cannot maintain a comfortable bladder that they maintain at the first fraction. So we need to ensure that there's adequate drinking protocol, and we should adjust the tamsulosin dose, because most patients on prostate RT are on tamsulosin. We might need to increase the tamsulosin dose so that they can keep a comfortably full bladder. And IMRT to cervix, which is essential if you are giving pelvic or parietic nodal boosts. The challenges for IMRT and IGRT cervix include, the main influence for cervix movement is rectal filling, and the main influence for uterus movements is bladder filling. And if there is gas in the rectum, the PTV moves forward. And also on cisplatin days, where we give a lot of IV fluids, there can be a very large bladder, and this can cause the cervix to move backwards and out of the treatment field, so we have to keep that in mind on cisplatin days. And also matching to PTV cervix and PTV nodes is an issue, because we need to make it to the cervix, but nodes need about 8 mm margin to prevent them from moving out. So this is a cervix IMRT and pelvic nodal boost plan which I have seen. So have a look at this cone beam CT. The cone beam images are in blue and the gray ones are the planning CT. So have a look at these images and see what you would do for this patient. Would you treat or not for this cone beam CT? So the images are a bit blurry here, but that's normal for cone beam CTs, and I suggest for the registrars to have a look at, get their eyes trained to see frequent cone beam CTs, so that you can get an idea, see beyond these blurry images of the bladder. So here you can clearly see that the bladder is underfilled here, and the uterus has moved forward. So this is due to irritable bladder, in cervix IMRT, that's the same issue as in prostate. So we need to modify the drinking protocol, because here the high dose PTV, the bowel has fallen into the high dose PTV and the PTV has been clearly missed. Challenges in anal cancer IMRT. There are 3 geographical PTV areas in anal cancer. There's the anal cancer primary, which is low down here, and we've got the inguinal nodes and the pelvic nodes. We need to assure an adequate PTV margin for all of these 3. As you can see here in the planning scan and in the cone beam CT, the anus has moved forward. So challenges in IMRT to anus, we need a lot of supportive care, because there's a severe skin reaction, and therefore positioning and setup errors, especially position at the bolus, is difficult, and we need to give adequate analgesics and laxatives. It's difficult to pass tools due to the pain, because there's a cancer in the anus, and that can cause distending of the rectum, and the GTV can be missed. So analgesics is very important in anal cancer IMRT. And other IGRT strategies for pelvic and organ motion correction. The first one we discussed, which is online repositioning. So we'll move to the next one, which is patient individualized margins. So here, this is used especially in cervix and bladder IMRT. In its simplest form, we create individualized internal target volumes between full bladder and empty bladder. So here the bladder is full, the bladder is empty. You can see the cervix, the uterus is moving quite a bit between these two. So we create an internal target volume particular to this patient depending on empty and full bladder protocol. So advantages, there's only one radiotherapy plan, but the disadvantages, the ITV would create a large PTV volume, and therefore it would reduce the advantage of organ sparing, and also we require multiple planning CT scans with multiple corresponding outlining for empty bladder, full bladder, half full bladder, and so on. Third option for pelvic IGRT and IMRT is plan libraries and plan of the day, where this is a typical bladder plan, where plan of the day approach has been used. So the CTV bladder is expanded by 5 millimeters increment with incremental isotropic margins, and we have created 6 PTV plans here. So there are 6 PTVs with separate 6 radiotherapy plans for every possible PTV we can assume by creating 5 millimeters isotropically around each CTV. So on the day of treatment, so this is the day of treatment. So we select the appropriate PTV plan, with appropriate PTV, and deliver the treatment. So this is used in cervix, bladder and rectum. Advantages, there's significant reduction in organs at risk, but disadvantages are it's very time consuming, and a lot of training is needed for the physicists and the radiographers to select the most appropriate plan each day, each plan of the day. And also still, even with all that, there is still some intra-fraction error which is not accounted for, and it does not account for all scenarios of the PTV. So sometimes we might get a bladder which is totally out of all the 6 plans we have. So at that point we might need to have an emergency 3D CRT backup plan to treat the day, to treat on that day. So that's it for pelvis. What are the challenges in head and neck IGRT? So the head and neck, the organs does not move like in the pelvis, but it has its own challenges. So one is the steep dose gradients and proximity to critical organs, and there is tumor regression, tumor regrowth during treatment, weight loss and weight gain. So we need to avoid prolonged steroid use, which can cause facial puffiness and weight gain, and also tissue edema is an issue, and setup variability mask fit is also head and neck. So the decisions we need to take in an IGRT for head and neck is, do we need to replan or not? Can we continue treatment till the replan is available? So the replan rate in UK auditing leads was around 10% for head and neck sites. And also we need to decide whether we need to change the frequency of con-beam CT imaging for a particular plan. So routinely we do that in Sri Lanka every 3 fractions and then weekly, but then for some plans we might need to do it more often than that. So few cases. So the first case, adjuvant radiotherapy to a T2 and node carcinoma of tongue. This is the first fraction for the con-beam CT. So the con-beam CT is in blue, the gray is the planning CT. So you can see there is there's some shift here. So there's a setup issue. There was a displaced mouth bite here. So we needed to repeat the con-beam CT with the properly adjusted. So the second case, T2 and 3 oropharynx, 65, 54, 2 dose levels in 30 fractions. Con-beam CT on the 20th fraction of IMRT plan. So what would you see and what is your decision? So this is day 1 plan, and this is the 20th fraction. So there's obvious tumor, there's obvious shrinkage of the tumor, there's an air gap here. There is no reduction in PTV is covered appropriately, but there is some air here. So the spinal cord in the remaining 30 fractions is going to be an issue because of the air gap here. So we need to ensure that the spinal cord is within the tolerance. We cannot exactly measure the dose of the spinal cord, but we can roughly estimating it by going back to the planning scan and creating this sort of a structure here in the planning scan, and assume it as air density instead of soft tissue density, and recalculate the dose to the spinal cord and assume that the next 10 fractions the same dose is delivered to the spinal cord. So we can assume and sort of do a rough recalculation to see that the spinal cord is within tolerance. It's especially important in brainstem dose for nasopharynx. This is a similar plan, maxillary antrum tumor. The tumor has shrunk and you can see the air gap here. So the brainstem would be an issue in this plan. The third case, a T3 and not post-laryngectomy patient, first fraction. So what do you do here? What can you see and what would you do? So this is a corn beam CT where, at least at Apeksha Hospital in Maharagama, the planning scan is in purple and the corn beam CT is color coded in green. So here you can see a bit of green all around. So that means there's more soft tissue seen in the corn beam CT than that was seen in the planning scan. So this is due to tissue edema. So tissue edema always causes underdosing of the tumor in head and neck plans. This is the first fraction, so we need to replan this patient, as it could cause continuous underdose. So there are exciting new developments in image-guided radiotherapy. So there is functional imaging and PET-based imaging, which can predict early response. So PET can be used to predict early response in radiotherapy, and we can decide the intensity at the dosage of treatment. And also there is the MR-Linac. So if you are worried about your corn beam CTs are not clear, you can't see them properly, well, the MR-Linac is the solution. They give very clear image guidance, and we can properly see the organs, and we can take good decisions in image-guided radiotherapy. So what are the challenges for image-guided radiotherapy in Sri Lanka? So at the National Cancer Institute in Apeksha Hospital, we have around 40 patients treated with IMRT every day, and IMRT is planned to be established in linear accelerators island-wide. So we need national level guidelines and IGRT workflow procedures for radiographers, physicists and clinicians, and we need to have levels of escalation. At what point do the radiographers escalate their problems to physicists and clinicians? We also need to improve the local IGRT audit. And what are the problems of IGRT in a resource-limited setting in Sri Lanka? Well, one solution is we can treat hypofractionated radical treatments can be used, so we can save a lot of money when we end resources. But when you're delivering treatment in lesser fractions, we need to be very confident that we have good image guidance techniques, so that the dose we delivered is actually given to the patient. So recommendations for implementation of a strategy of institutional IGRT. So this ensures ensuring consistency between treatment intent and the IGRT approach utilized, and ensuring minimum national and international IGRT guidance is followed while considering the benefit of daily volumetric image-guided radiotherapy, and ensuring the appropriate allied health professionals, namely radiographers, therapists, and leads undertake IGRT, ensuring the IGRT workflow procedure is clear and includes an escalation process for difficult setups, and ensuring a robust IGRT service in place before implementing advanced adaptive approaches. So, in conclusion, there cannot be any IGRT. We cannot have IMRT without IGRT. They always go hand in hand together, and we have to always be confident that the plan we prescribe in IMRT is actually delivered to the patient. So I'd especially thank Mr. Atula Vijaykumara, Chief Physicist at National Cancer Institute, Maharagama, and Mr. Tilak Silva, Chief Radiographer at Selinko Healthcare, for providing me with images. And these are my references. Thank you.
Thank you, Naduni, for your excellent talk on rapidly evolving topic. So now is the time to have some questions. There are few questions coming up, and I think you have answered some of those questions, but I think only the person who is asking the question can read them. So for the audience, I will ask those questions again from you to get a clarification. So first question is, what is the place of IMRT in radiotherapy for lung cancer?
Well, thank you. So, well, I did talk about lung because we don't use a lot of lung cancer IMRT in Sri Lanka, and sort of a complicated topic. That's why I didn't include that in my talk. I just concentrated on pelvis and the head and neck, which is what we do mostly. But I think we can't have lung cancer IMRT without image guidance, especially for SABRE. We need 4D scanning images, and also even without a 4D scan, we can do with 3D. With the electric on view we have, even without a 4D simulator, but we need to just use a bit of bigger margins. But anyway, for lung, all IMRT and SABRE for lung definitely needs at least minimal a quantum CT to verify whether the lesion is in the proper position. And talking of a lung IGRT, it's not, the lung is not as difficult as the pelvis, as in organ, as in sort of, there's not much of a motion within the lung tube, it's just a respiratory motion. So if we can put sort of a bigger enough margin to encompass the respiratory motion, and if we could deliver that within the lung tolerance, we can actually go with, even with the 3D quantum we have, we can actually go for IMRT in lung. But for SABRE, I think we would need a 4D simulator.
The second question, there is a question in a IMRT plan, if the PTV is not missing and OR is not matching, but still if the plan is shifted, how would you manage such a situation?
So I think this is about the convening CT, isn't it?
I think the question is actually the cone beam CT is showing that PTV is within, and also OARs are not OARs are matching, but still there is some shift. So asking whether you proceed or whether you do anything in such situation.
It's a very good and interesting question. So this is actually quite a clinical decision. So we mainly concentrate on make sure that the PTV, that the conding CT image that we see, say the prostate is within our PTVs. Now, our main thing is to treat the PTV, treat the tumor. So that's our main priority, that's number one. And the second one is we have to make sure that the organ at risk is not within high dose CTV. Say like, so the bowel is not falling within the prostate 7 to 8 grade PTV. But that is just for one fraction, isn't it? So I would think it's a clinical decision, really. That's why that's where the radiographers would sometimes need our clinicians, our registrars, our oncologists' input. So we have to decide whether we should go on with this vaccination or whether we should sort of change the protocol a little bit and see. But I think it's more of a systematic error. So if we sort of see the same problem every day and your organs at risk are always falling into the high dose PTV, we would be concerned because the bowel would obviously exceed tolerance. So at that point, we might need to sort of intervene. But I think the main focus would be, so first is the bony match, the second is the target PTV, the GTV is covered, and the third would be organ at risk. We need to make sure that during the vaccination it is within the organ at risk tolerance.
Okay, Naduni. And another question is coming up. So what is your view of using IMRT in pediatric practice?
Well, I honestly don't have too much experience in pediatric radiation oncology, but from what I've read actually is I feel that there is no real evidence up now to say that there is any late effects or long-term malignancies with using the low-dose bar. But and I think from what I'm aware is the practice is if you can encompass it without IMRT, you could do that. But if you get a better sort of dose distribution, you can go for dose escalation with IMRT. I think in pediatrics, they do go for IMRT, and now it's more for protons for pediatrics. So I think that's where pediatric radiation oncology is evolving.
Okay, and you talked about low dose bath in pediatric oncology, so that I thought of asking a question. So first question was actually the place of IMRT in lung cancer. So what is the effect of that sort of a low dose bath in lung IMRT? Is that a concern in moving forward with lung IMRT?
Well, as far as I'm aware, and I have sort of come across, I haven't come any evidence of having second lung cancers due to the low dose bath due to the lung, and it's sort of considered mostly as it's not having much of an effect. And also in lung cancer, the survival is quite less mostly, and people are usually quite an elderly population, so maybe the effects don't actually come up during their lifetime, but this is all just hypothesis and theory. I haven't come across any evidence, to be honest, that this low dose bath that people are worried of is actually causing any effect.
Okay, and there is another question. what is the place of VMAT in radiotherapy to prostate cancer?
Well, I think VMAT can give a much conformal dose distribution than step and shoot IMRT, and VMAT is also quicker than TOMO. So I think a lot of people actually do use VMAT for IMRT if it's available.
Okay, some more questions are coming up. So next one is, what is the reason to use different dose fractionation schedule in IMRT within brackets while the biology remain the same? So why we use different fractionation schedule in IMRT? That is the question.
Yeah, so that's a very, very, very good question, and it's very interesting because so at least in the UK, they always try to sort of hypofractionate and give, especially the NHS is sort of government dependent just like us, so they're sort of lacking in funds, so it's sort of budget is really important. So they try to deliver the same thing within a shorter fractionation. We can save a lot of money, like millions of whatever money in the country. And also, it's very easy for the patient to go for hyperfractionated regimes because less frequent visits, and the side sort of the effects even come later. Say, for example, like in prostate. Earlier, it was treated like sometimes it's treated like in 37 fractions, but now in the UK, it's moved to 16-20. It's said to be non-inferior to the 37 fractionated regime. So in that setup, it's much easier for the patient. It's just treatment is over in 4 weeks. And also the sort of the side effects like, the urinary problems, the rectal problems, they come sort of once the treatment is over. So it's much easier for the patient to continue the treatment and have the treatment over and then deal with the side effects later. That's also one. But the problem with when we move into hypofractionation is that we need to be sure that we have given proper dose, that our IGRT technique is 100% accurate. Because if we're treating something in 20 fractions, say like a saber, if we're treating it in 5 fractions, what we should be treating like 30 fractions, we should be sure that the 5 fractions we delivered are actually delivered to the tumor, and the organ side risks are definitely excluded from this very high dose. That is why what I mentioned in my talk, that moving forward in Sri Lanka, we should move to hypofractionated regimes, and IGRT is super important in that setting. So I hope that answers the question of why we're trying to sort of use different fractionations to get the same effect.
I think time is also running out, so we'll conclude the session. And again, Naduni, thank you so much for giving this wonderful talk on very interesting and very rapidly evolving topic. We can talk this for hours, but unfortunately we have only half an hour and we have to conclude and move on to the next session. Thank you so much.
Okay, thank you very much, everybody.